So, we are basically doing this fireside chat as recognizing the signs, saving lives, raising awareness of myocardial infarction symptoms. So, myocardial infarction contributes substantially to the toll inflicted by the coronary artery disease, and timely recognition and appropriate intervention are necessary for favorable outcomes. The session will highlight both personal experiences and the support from the private partnership in raising awareness. The discussion will explore how we can effectively educate communities about the symptoms of heart attack in diverse population, identify barriers to early detection, and the critical importance of acting fast. At its core, this session affirms that effective communication and improved outcomes start and end with the patient, supported by his or her family, care team, and broader system of support. So, the objectives of this session would be to highlight the importance of early recognition and timely response to myocardial infarction symptoms, share real-world experiences and lessons from the patient perspective to underline the human impact of delayed care, explore public health communication strategies and the role of different sectors in improving symptom awareness, and finally, to discuss the gaps in awareness across different populations and how to tailor messaging to vulnerable or underserved groups. So I have two panelists here. I have Dr. Joris Wucht. I pronounce it right?
That's fine, yes.
Wucht. Okay. I'm happy.
Vught.
Wucht.
It's very difficult to understand for many.
Okay. Senior Medical Director, External Customer Implementation Lead for Viatris, and Ms. Hywel Ferguson Davis, Founder and CEO of the Heart Sisters. So, Joris, I would just call it Joris.
Perfect, yes. Two English words, your and is. So, yes.
So, what do you see as the most significant challenges in raising public awareness about the symptoms of heart attack?
So, first of all, I think it's very important to raise awareness. What I've learned and what I of course knew, but what has been discussed yesterday and today is the increased number of heart attacks, for example, in certain regions in the US. And we also know that if you look at mortality in MI, it quite often happens pre-hospital admission, about 30%, and about 10% of the patients during the actual admission. So these patients are at obviously extremely high cardiovascular risk. What makes it difficult is the fact that there's lots of focus on risk factors and prevention initially. But when we look at secondary prevention, the population where we talk about right now, is that I'd like to compare it with stroke. Everybody knows the risk factors of stroke, the symptoms. So for example, Be Fast is an acronym that's often used, and it refers to speech, it refers to several other elements related to stroke. I can't remember the exact details. It's balance, Be Fast, the E is from eyes, and
blurred vision.
Blurred vision, that's the eyes, the E.
Speech slurred.
And then we have the S from
Slurred speech.
And the T is time.
Time to call 911.
So, and now we are talking about strokes, but what about acute MIs? So, I think this is the tricky part, because symptoms change per individual. Symptoms change between a first and a recurrent event. And I think a good example is what we've also discussed, the difference between genders. So if we look at male, it is shortness of breath, uncomfortable chest, And when we look at a female, you do see more elements related to vomiting, anxiety, and others. So I think that's the difficult part. It's scattered, the symptoms. It's not very simple compared to, for example, stroke. I think that's the key element, Dr. Narura. Thank you.
And let's go to Haiwell. And Haiwell, in your personal experience and in your opinion, how do we ensure that the awareness efforts truly reach and resonate with the communities most at risk, particularly in the underserved situations?
Yes, first I want to thank you for even having me on this platform to really tell my story.
Yeah,
And the effects of what happened to me initially.
Right.
I was diagnosed with gestational diabetes at 38 years old. At 41, I had a stroke that led to a quadruple bypass and a heart attack. I then again had a second heart attack. And today I have 10 stents inside of me. And we think about the journey, and I talked about it yesterday. It's not one singular event that occurs. It's catastrophic. How do we mitigate the circumstances that leads? And so it's so important that we know the burden and understand what happens. And how do we treat a patient past an event? How do we look at the systematic failure that happened in my case? Because I went to the doctor and I complained. I went to the ER and showed up for myself. I was dismissed and denied. And I hear this far too often, especially in people of color. Women also. So the burden is put on the patient to then treat the symptoms of a situation they have no idea. And then you throw your family into it. What happens as far as caregiving? You're sick and you have to rely on people. Medication, pharmaceutical, PCP, burden of medication, and adherence. And how do you get from a place of not knowing to be informed? It's treacherous. And for a patient, the burden is on the patient. And that's why I looked at my situation, I said, it's not right. A person doesn't have to go through this. Knowing the medication that we have and the stuff that we have available, to say, I understand that, listen, that we want to live. And we have to take the burden off of the patient, understand that there's more to live, there's more to life. You know, I went to my doctors, I complained. I told them my symptoms, and I was still dismissed and denied. And far too often it happens way too many times. And so I said it was not right. And in my community, I tell the women that I serve, because I create an organization, no one's coming to our rescue. The fact of we have to be proactive in our own lives and have a voice. And I didn't know how powerful my voice was until I started telling my story. And then people started to listen. And they found symptoms, and they went out and they understood that they have to fight for their lives, even in my own family that didn't understand the burden of proof. So it's important that we elevate the patient's experience and look at the burden of the unmet needs. And the system is there, and we understand the system is fragmented, but how do we move the parts so that we all can live?
So
Thank you very much. If
so
I may,
sorry, go ahead.
if I may add one element, I think your story is so strong. And for me, the first thing that comes to mind is we talk a lot about raising awareness, education for patients or individuals at risk. But what we do forget is we also need to educate healthcare professionals themselves. And I think this is a great example that you share. Thank you very much.
And what exactly are you doing, Haiwell? How exactly are you spreading the awareness in the communities? How are you trying to empower them? What exactly have you done about it?
It's so important that we look at micro-organizations and patient-led advocacy organizations, because we know exactly what's going on with the patient. And far too often we give basically the big organizations funding. But it's the micro-organization that's going in the community. I know in my community, there's an issue with trust. And it's different when we come in the community and say, hey, let's get together and form a relationship and talk about the burdens then I see the layers, come about. And I can say, even in my own family, my son, he wants to be a firefighter because of what I went through. My daughter is in school. She has a CPR event where the little children go home and they explain to their parents, do you know CPR? So it starts at the ground level when a patient has a voice to say, it's not enough. It's not only one person. It's going to take community. But I feel like the community starts by an individual, but when we get together, we can be marvelous. So I created an organization called Heart Sisters, addressing the needs of people that look like me, women of color predominantly, that are underserved, that have been neglected, or even to themselves don't know their worth fighting for because of the burden of economics or social determinants. Then they put basically their health care on the back burner. But at the end of the day, we all want to go home to our loved ones. And the fact that we get together and start those meaningful conversations about hypertension, about diabetes, about bad cholesterol. And a quick story, I just got a diagnosis 10 years into my journey of bad cholesterol. And had I known that, it would have mitigated a lot of stuff that happened. I had a second heart attack, and I was still fighting for certain drugs, being an advocate where people weren't listening. So it's important that we understand the burden has to be lifted by understanding the patient, and truly getting to understand what is needed.
So, now from your side, what kind of public health campaigns could better engage families and caregivers, not just the patients, in recognizing the signs and symptoms of the heart attack? So how can you come around and support not only the volunteer organizations, but what exactly can you do about it?
So I think what we do in Viatris is we go beyond, providing our medicines and really look at the unmet patients' needs that exist and also care pathways that needs to be improved. So I think in general, yes, we'd like to be involved and work in unison with all the partners that we have, whether it's civil society, patient advocacy, governments. We have those connections historically as an organization, but also because we want to make sure we get the medicines to the right patients at the right moment in time. So within this network, we need to collaborate and we need to learn from each other. And we should not limit ourselves to the focus, as I mentioned before, on patients or healthcare professionals. What I think is extremely important is to bring the caregiver, relatives, family members into the discussion. They play an essential role. And they need to also understand what their role is. It's not just about the awareness of the symptoms. It's also about what role can you play and what role do you need to play. We obviously hear stories regularly about individuals experiencing a heart attack, and they kind of bring it down. This is probably not a heart attack. I just ate something badly, or I'm just tired. I go to bed. And this can go wrong. The opposite happens as well. But I think in this case, if family members, relatives, caregivers, close to the individual are there, they are definitely happy to support. What makes it difficult, I think, is that we're all different individuals. So we have different backgrounds, different needs. Important elements related to this, I think, are who are the individuals that we trust, whether it's a community worker, a religious leader, whether it's your spouse. It's an important element. The other one is that recently we published a paper on generational differences in healthcare. This is also very important. This is the first time ever that we live with 5 different generations at the same time. They all have different needs. They all have different preferences. They all look different at healthcare, at doctors. The baby boomers, they have lots of trust in their healthcare professional, while younger generations own their own health. So all these factors kind of make it very difficult to come up with a, let's say, one general solution. Therefore, listening to each other, collaborating, also leveraging social media is going to be crucial to make significant progress.
So let's jump on to you. And you have been now engaged with the community, you have been engaged with families, you have engaged with the patients and all. So what do you think are the barriers which prevent the individuals or families from recognizing and responding to the warning signs and seeking care as well?
Yes, I can tell you a story where I was at the hospital and they thought I had a TIA. And my sister advocated for me because they were going to release me. And she was basically telling them, no, she was not going to leave. I was not going to leave. And she stayed there, and they were going to put her out of the hospital. They called, actually, security. Come to find out I did have a stroke. And once a patient is sick, they don't really have a voice. So it's important to bring all family members, because I said, it's not the patient only suffers, the entire family suffers. So it's making sure that you have that care team, that support system. In most cases, a lot of people don't have that. Now, how do you negate that fact, and how do you bring a support? Goes back to making sure community is there. And how do we understand that? And I felt the need to have community by creating an organization because there was none like it. I needed help. I needed to live. And I absolutely had no idea how to do so. So I found my issues, and I looked at it from a systemic issue, knowing that I needed to live. And I look at my community and the people in my community, and I learned everything I've learned about my issue of dealing with the navigation of health care, of my care. And I found a solution when it comes to what I've dealt with, and I implement it. And it's actually saving lives right now. And that's just one voice. A person that wanted to live and understood that I had to make the necessary changes. But it took an approach of bringing everyone in. Understanding that I needed to work with my physicians. I needed to understand not only the name of my medication, but what they were. What were the side effects to those? Speaking of my pharmacist, but most of all, taking accountability for the role I played in it. So if we can build that patient to understand their life is valued, I think that's a missing component. We know that the healthcare is there, the doctors are there with knowledge, the pharmaceutical have all the medication available. But how do we bridge the gap? An informed patient is a powerful thing. And I think we need to listen more to that.
So if we take it further, Haiwell, what role does trust play when we talk about the symptom awareness and action, and how do you think the healthcare professionals can help in it?
Yes, I can say in my community there's a major issue. On certain demographics, it is. What I feel like when I go to my community, it's different than having a person of a different origin or ethnic background. So they need to see people that look like us, talking to them, conversating with them. I urge a lot of people to go in the medical field, be a nurse, be a doctor. Because when you have skin in the game, it changes. And you break down the barriers, especially when it comes to research. You know, somebody reached out to me recently, and I did a really good post. I'm like, stop complaining. If you want to be part of the solution, we're going to have to show up at the table. And that was a call of action that I got some responses for. Now, had someone else said that, it would have come off different. So it needs people like us, making sure we're there at the table, understanding the unmet needs, addressing them together so that we can create change systemically.
So have you been able to enthuse people around you to start such support groups or patient groups or things like that? Or is it that you are trying to just focus into your own group? I mean, have you been able to kind of pollinate and go around and raise more groups around you maybe for the different diseases, like you are predominantly focused on the cardiovascular network. So have you been able to create the other groups around you?
I am a heart connector by heart.
Right.
But understood there's a lot of comorbidities that exist.
Right.
Hypertension, cholesterol issues. And this all leads down the same spiral. Even the fact of renal issues, kidney failures.
Right.
And it's all related. And so, like I said, our organization is reaching, and we're doing something groundbreaking, because we're not looking at basically, and I get emotional about it, because it's personal for me. We're doing something groundbreaking. We're going beneath the layers, and we're touching the matter. And that's what counts. And so our organization is growing rapidly, and I'm so grateful for everyone that has coalesced and is building us up together.
Thank you. And I think one most important question here is from the industry side, which I would like to ask. We had done a report on STEMI for the resourced challenge settings. And we have guidelines which are absolutely superb guidelines, which we have from European Society of Cardiology, American Heart Association, American College of Cardiology, which we want that everybody should follow. But there are certain limitations, and for that, we really need the implementation science there. And for example, I have often talked about India, where all kinds of medical services are available. However, very small fraction of the people are able to get the primary angioplasty. Leave aside meeting that 90 minutes goal and things like that. Right? There are primary healthcare centers in India, and all these people who live in the rural areas, they go to the primary healthcare centers. You do not have even electrocardiograms there. So a patient with the chest pain goes there. What exactly is he able to do there, or she able to do there, right? So what we had proposed was that at least the primary healthcare worker, whatever level of worker or physician extender or social worker or whatever he or she is there, they basically should be educated enough to recognize whether it is more likely to be a cardiac pain or not cardiac pain, although it's not easy, we all know that. Even at our level, it may not be as easy. But even if they are able to roughly differentiate between cardiac and non-cardiac pain, we suggested that just they take the non-coated aspirin, 375 milligrams, put it into water, dissolve it, and let them drink it, right? At least it will keep some of their platelets going, and not let them aggregate there. And at least till the person reaches a place where they can receive the thrombolytic therapy, or if they are lucky enough and they reach the place where they can get the angioplasty, at least we will keep some blood trickling in there, right? What do you think there is a role of innovation in such places? What role industry plays? And are you thinking of certain things which basically do similarly, which can keep the platelets from being aggregated and keeping the blood flowing? I mean, what are the innovations that are coming our way? Are there some clinical trials which are happening? Is there some knowledge which exists around that?
So thank you for the question, Dr. Narula. So, I mean, as Viatris, we are definitely focused on cardiovascular disease, and we are looking for unmet needs, and we try to better understand the patient journey and the kind of gaps that exist and opportunities to reduce risk. So currently we are evaluating a self-administrated subcutaneous C2P. Now, I'm always confused. platelet inhibitor in patients who experienced a recent MI. And we look at the efficacy and safety on mortality and morbidity in patients. So that is a potential opportunity for the future. Yes, thank you.
And what are the trials that have happened in that area, or what are the trials which you are planning or have already been taking place?
So there's currently a trial ongoing, a global trial, exactly looking at this specific topic, which is ongoing, and it's an endpoint-driven trial, so it will probably read out 2027. So, I mean, it's a clinical study, it's an evaluation, so it's very difficult to say anything about the future.
So, would you be able to tell us something about studies like SOS, AMI, and things like that?
So that's actually the study that we currently have on global. We are recruiting in many different countries with many sites. So that's something that we are able to talk about more. I mean, we have those conversations at country level with investigators, accelerating recruitment to ensure that we better understand the value of this antiplatelet therapy in the acute phase. So the idea is for individuals at very high risk, so who are at risk of a recurrent event, and as soon as they are experiencing symptoms, they need to self-inject themselves, and this is a placebo-controlled study. So it's currently ongoing, as I mentioned. So details will be announced later. Yes.
So you expect a patient-level intervention here, or pharmacy-level intervention, or some kind of a community healthcare center-like intervention? What is going to be the level of intervention?
So it is the actual patient self-administrating the medication. So that's also a reason why it's so important for patients at risk, or also family members and the broader community, to be aware of what those symptoms are and how they can be supported. In general, when we talk about the golden hour, so the first hour after an event, that's the opportunity to make sure that short-term and long-term complications are being reduced. So a very exciting opportunity that could potentially shift the treatment paradigm in secondary prevention.
And I'm sure that these are the type of interventions where champions like Highwell and all, they will be able to play a major role educating their community, carrying it themselves if needed, and if kind of considered important by the professional cardiologists and all. I think that would be an important intervention at that level, disseminating the information and all. So thank you very much. Unless there are some questions from the audience. Yes. Here.
Thank you so much. It's very, very inspiring to hear and to hear the connection between what the pharmaceutical industry can do and a community-based approach, patient-based approach. So my question is, how do we go a step further, and how can we, just from your experience maybe, Hivel, how can we link the lack of trust and the trust you've already built on your level? So let's start from there. On your level, with your community, you are a trusted source of information and knowledge because you come from your own experience.
Yes, I have.
And according to the latest trust barometer by Edelman, people trust people like me, okay? That's 75% of trust goes to people like me. According to the global risk assessment, the biggest risk we are facing is the propagation of misinformation and disinformation. So I'm just pasting the context here. You have, who is the trusted source of information and the massive channels of misinformation and disinformation. So how can we, on that level, bridge that gap and and work with the healthcare professional, work with the industry, and I don't know what else platform, and where can we as a federation come in to give you also the data and the power, if you want, the evidence base to go after the wrong information. So it's one thing to build trust, but it's another thing to go proactively to fight information that's wrong, health information that's wrong, misleading, and dangerous for your life. Thank you.
Thank you for that. And one of our motto at Heart says is for us, by us, which is so important. And we knew actually we needed some help. So I reached out to organizations like Global Heart Hub for structure to understand, and I reached out to many organizations, pharmaceutical also, to build that trust to understand. And we lack funding, and that's a major issue in our arena. And there's a lot of micro organizations in my community that are doing the footwork, and we're self-funding. And so if we can bridge that gap to build up our micro communities, I think we can save lives right now. Because I see the lives we're saving by understanding and building that relationship to go beyond the barriers. Because like I said, it looks different than someone coming into the community. That's why we reach out to the football fields. We go into salons. We go into the churches and start those meaningful conversations that are not there. So our voice is amplified when we speak to ourselves, but we need that support to undergird us, to build us up, to make it lasting.
So thank you. Oh, sorry, there is a...
Thank you very much, my lady. I can feel your passion, and I quite sympathize with you. But science is evidence. Have you tried to do some studies? Have you tried to get some data? Have you tried, you understand what I'm saying?
Yes.
This patient, these salons, this swimming gadgets everywhere, there must be like documentation, that you can share with everybody. And once we see this, that you are able to get to the root, grassroots. I'm a grassroots person. Mm-hmm. I love going to the grassroots. People that really need to be reached, the unreached, the unlearned, people that will really need to get informed. And then once we see this as scientists, you get it back. Yes. Thank you.
So we conducted this year, actually, was a needs assessment in our community. We reached out basically first to the hospitals, and we gathered their needs assessment, and we went in the community and asked them, even the fact of what is your cholesterol levels, no information, which we found that our community is not involved. They don't understand. And that's a major issue. Even the basic stuff, it's not there. So we understand we're at grassroots level when we have people that are not there for themselves and don't know the information. So we're starting to build up that. So we do have basically data, and we're building data as we speak. In our organization right now, there's 850 women that we know have an event or is living with a comorbidity. So we understand the systems, and we are working them, and we're, like I said, we're built up with other organizations. But like I said, in our community, and there's a phrase that I heard one time, a statistic is a cry from the grave. And we can't wrap it up and just put a number on everything. It's lives we're saving. And we have to undergird the smaller, like I said, the micro organization to make sure that systemic changes. It is possible, because I believe that completely it's the missing component. We've tried a lot of stuff. There's a lot of seminars that happen. But what happens Monday morning in the office or in the waiting room? It needs to change, and that conversation needs to happen.
So, if no more questions, and if you want to add anything, Joris, or
No, I can only repeat. I mean, many of us, almost of us, have, individual stories, because we are all connected to cardiovascular disease. And I think that's very strong, and we need to leverage those stories. And yes, from the top, as a pharma company, we can, invite, patients to attend meetings like this, but we need to go all the way down into the communities to really have impact. Look individuals in the eye because, and create the trust that is needed. And that's not us, that really is our, the community workers, the caregivers, family members. And in your community, they must be very lucky with you, but that's also a problem. You need to have engaged and dedicated individuals to do the actual work, which is very complicated.
Or any possibility that industry like yours, going to the churches, doing some screening programs for them, going ahead and doing the cholesterol levels, blood pressure checks, their assessment of the risk profiles and things like that, so that there is more awareness in the community, and the trust increases even in the volunteer organizations like that.
Absolutely, yes.
Great.
Yes.
So with that, thank you very
Yes,
much.
I want to add something.
You want to add?
Just in closing, I'm just one voice in a cry of many. And the urgency is right now. We have an opportunity to change the matrix and change numbers, and we can do it. That's the call. And that's from a patient's perspective.
Thank you.